pathogenesis of COVID. So you can see here that you have the, sorry, just one second. Just one second. Okay, just sorry, but can I just, I think there's a problem with my sharing. Are you able to see?
Yes, yes, we are seeing now.
Oh, okay, sorry, there was some problem with it. Okay. Yeah, so what you can see here is you've got the virus here, which attaches to the ACE2 receptors on the cell. And you can see that the transmembrane protease type 2 cleaves the ACE2 receptor from the spike protein, and the virus gains entry into the cell. And this leads to a cascade of inflammation and thrombosis. And this has formed the basis of the different modes of therapy, ranging from antiviral therapy, immunomodulators, and anticoagulation with or without antiplatelets. There's a lot of studies looking at that. And before I go into the controversial topics, I'll just very briefly, over a minute, just cover the evidence for dexamethasone just for the sake of the trainees. So this was the big study which came out in June, mid-June last year, which was the recovery study, which showed evidence of benefit in all participants, especially those in invasive mechanical ventilation and oxygen. But in the patients who did not receive oxygen, there was no mortality benefit. And on the basis of that study, dexamethasone 6 milligrams IV OD for 10 days formed the basis of therapy, one of the bases of immunomodulation in COVID-19. I just thought I should just show this big meta-analysis which has come out also, which has shown that dexamethasone definitely has a mortality benefit as opposed to hydrocortisone and methylprednisolone, which didn't show us the same effect. Moving on to remdesivir. So remdesivir is an antiviral therapy. This is the ACT-1 trial, which came out in full print in November, early November, in which they actually randomized patients who had either radiographic infiltrates or desaturation, or those who required supplemental oxygen or mechanical ventilation, to receive either remdesivir or placebos. We can see there were 1,062 patients who underwent randomization. And what we can see here, that the time to recovery, that was their primary endpoint, the time to recovery seemed to be less in the group that was receiving oxygen, but did not have benefit in any of the other groups. So the patients who were on mechanical ventilation, patients who were on high flow oxygen, there was no evidence of benefit. And this is the same thing which is showing that the median time to recovery was less, especially in the group who were on oxygen. We can also see here that remdesivir had improvement in the ordinal scale, which I'm sure most of you would be familiar with, and had improvement in the median duration of hospitalization, and improvement in the median duration of people who required oxygen if they were receiving oxygen at baseline. We can see here that there was no difference in the duration of requirement of NIV if remdesivir was started in patients who were on NIV or mechanical ventilation similarly. Now, the WHO Solidarity Trial also has come out in Feb this year, and that showed that there was no difference between remdesivir and the control arm, but they did find that there was a trend towards benefit in the patients who were not ventilated. This was the mortality benefit in the patients who were not ventilated. In the same recovery solidarity trial, they actually put together a meta-analysis of all the other trials on remdesivir, and they found that in patients who are on low flow oxygen, as was found in the ACT trial, and the lower risk groups, there may be a benefit in terms of mortality in remdesivir. So if you're starting remdesivir, it is better to start it early, especially when they are started on low flow oxygen. There's probably no role of remdesivir once they are on high flow oxygen, NIV or intubated. Now, moving on, we've all seen a lot of COVID patients, and we've seen them come into ICU, they deteriorate, and there's several possibilities that we consider when they deteriorate in our ICU. And this is based on a combination of clinical examination, radiology, ultrasound and chest X-ray, and sonological examinations. And what we think of when you see a patient is deteriorating, is it because of underlying disease worsening? Is it because of a new infection? Is it because of other normal things that we see in an ICU, like collapse, pneumothorax, fluid overload of tube block? And when you look at underlying disease worsening, people have proposed that cytokine storm, inflammation could worsen the patient's underlying condition. Thromboembolism is another area which people are interested in looking at, and fibrosis. Now, for inflammation, we know that there will be a role for immunomodulators. For thromboembolism, there is this controversial role of whether we should give therapeutic or prophylactic or intermediate dose anticoagulation. We need to check whether the anticoagulation is adequate. And for fibrosis, as of now, there is no magic therapy. So moving on to cytokine storm, this refers to a severe immune reaction in which the body releases many cytokines. There's no standard definition. This cytokine storm is more like an umbrella term, which covers a lot of organ dysfunction. It may be fever and hypoxia, DIC, organ dysfunction, elevated levels of IL-6, decreased T cells, NK cells. There's no standard criteria which has been laid out for cytokine storm in COVID-19. I just wanted to show you this graph just so that you all understand the amount of, this was the original cytokine storm, which was described about 10 years back in a patient who received chimeric antigen for cancer. And you can see that the IL-6 levels were close to 3,000. Now, this is the IL-6 levels which has been seen in ARDS, which has been reported in ARDS trials. And in COVID-19, this is where the IL-6 levels are. Okay, so again here, just to show you, this is the alveoli FACT and SAILS trial, which saw IL-6 levels in the range of thousands. But look at the levels in COVID-19. It's actually much lower. But the interest in tocilizumab came about from initial retrospective studies, which showed that the probability of mechanical ventilation and death was less in the group who was on tocilizumab. And that led to a cascade of prospective studies. As of now, there are 60 published studies in tocilizumab, of which about, I think, 18 are prospective and 6 RCTs have come out. So there's a lot of evidence on tocilizumab in COVID-19. Now, I am particularly fascinated by this trial. This is the Co-Vactor trial. Now, tocilizumab is a drug which is produced by Roche, and Co-Vactor is the trial which was sponsored by Roche. And they studied actually patients who had severe COVID-19 infection. So these are patients who come to the ICU, low PF ratios, desaturating. They were excluded if the physician determined that death was imminent or inevitable within 24 hours, or if they had an active infection other than SARS-CoV-2. Now, what the study did was they had 452 patients randomized in a 2:1 ratio to receive tocilizumab and placebo. And what you can see here is that there was no difference. Their outcome was the median change in the 7-point ordinal scale. And they also looked at mortality. There was no difference between tocilizumab and placebo. And mind you, these were patients with severe COVID-19 pneumonia. The MPACTA trial was another RCT, which actually looked at tocilizumab and placebo, again in a 2:1 ratio. But you can see here that patients on ventilation were excluded. While this study actually showed some amount of benefit on primary outcome in terms of mechanical ventilation, you can see that the p-value is 0.04 in favor of tocilizumab. I want to just highlight to all the trainees that in this study, patients on ventilation were excluded. The Corimino trial is another trial which came out, which actually compared tocilizumab and placebo. Now, this was in patients who had moderate, severe, and critical COVID disease, very similar to the Co-Vactor trial that I presented earlier. Again, here, there was no evidence of benefit. Now, but there are two major trials which have come out, the REMAP-CAP and the recovery trials, which have shown that there could be an evidence of benefit in patients with COVID-19 infection. So these patients who were included were patients who were in the ICU within 24 hours of commencing some kind of organ support. They were either patients on tocilizumab or sarilumab versus placebo. And the primary outcome was combined in-hospital mortality, days free of organ support to day 21. And while you look here this was their primary outcome, was the combined in-hospital mortality. They actually broke it down to the subcomponents, and they said that tocilizumab actually had, you can see here that tocilizumab had less deaths as compared to the control. So 28% in-hospital deaths as compared to 35.8. But when you do the combined outcome, it's very difficult to say, but mainly in terms of the deaths is what they have compared and said that there is less deaths in tocilizumab. But I just want to highlight to the trainees, very, very important to look at a trial and analyze it. Don't just take it at blanket, that this is published in a big journal, this has to be the truth. This is a journal with a low, this article has a low fragility index. By fragility index, it means that if I remove 3 patients or if I put 3 patients in either arm, the whole outcome changes. And you want to have studies with high fragility indices. So this study essentially is limited by this low fragility index. And so clinicians, there may be a role of tocilizumab in severe patients, but we need actually bigger studies in ICU. And there was a subsequent systematic review which was done, which if you can see here, these are all the retrospective studies which looked at the mortality, okay? Even though the p-value for retrospective studies was significant, there's a huge amount of heterogeneity of the studies. So that means these studies actually technically cannot be compared. In the prospective studies, the p-value was not significant in terms of decreasing mortality. Similarly, they took only the RCTs that have come out, the 6 RCTs, and they looked at is there any evidence of benefit? It may be there may be an evidence of benefit, a trend towards benefit, but it is not clear. And as I said earlier, some trials were done in patients who are critically ill, whereas some were done in patients who are moderate illness. I just want to, this is a trial which has come out from India, Dr. Dhruv Chowdhury's trial, which actually looked at, it's called the Corbin trial, which looked at patients with moderate to severe COVID disease. Their primary outcome was progression of COVID-19. So they looked at whether the moderate illness becomes severe, whether severe goes on to become death. Now, in this trial, one thing to note is, unlike the other trials where they used 8 milligrams per kilogram, in this trial, they used 6 milligrams per kilogram of tocilizumab versus placebo. This was mainly, a middle-aged group. I mean, 56 was the median age in both arms, but there was no difference in the primary endpoint. So this has come out very recently, maybe about, I don't know, a couple of weeks back, which has found no difference in the primary outcome in terms of progression of COVID-19 up to day 14, and no difference in secondary outcomes in terms of ICU, hospital, 28-day mortality, and ventilator-free days. But in this study, they have highlighted, they've just looked at this subgroup of patients with severe disease. And even though this was not their primary outcome, so this study was not powered to find this, it said that there was less number of patients who progressed from severe disease to death in the tocilizumab arm. So the authors have suggested that bigger studies need to be done in severe patients in ICU to find out whether tocilizumab is actually beneficial or harmful. The NIH, as of now, recommends tocilizumab as a single dose in combination with dexamethasone in patients who have rapid respiratory decompensation due to COVID-19. I must tell you that the number needed to treat for tocilizumab to save 1 death was 25 patients, and we must keep in mind the cost involved as well. It's very important that you avoid tocilizumab if the patients are immunosuppressed, if the ALT is 5 times the normal, in patients who have a high risk of GI bleeding, uncontrolled infection, absolute neutrophil count less than 500, platelets less than 50,000. So these are the things which you need to keep in mind when you're starting patients in tocilizumab. Very briefly, just one slide on this.
May I just interrupt, if you don't mind? For the trainees, is there any role for measuring interleukin or CRP as a marker of some kind of a cytokine storm or hyperinflammation going on now before starting?
See, as of now, as I mentioned earlier, I showed the IL-6 levels there is no real role of monitoring IL-6 or CRP. In fact, actually, just the other day, we had a patient in ICU where tocilizumab was given and the IL-6 level actually jumped after 2 doses of tocilizumab. So, most of the studies were not really looking at biochemical markers. They did look at, if I go back to the studies on IL-6, it was one of the secondary outcomes. That was not their primary outcome. Primary outcomes were looking at death or organ support free days. That was their primary outcome. So it's very difficult to say whether there is a definite role of monitoring IL-6 or CRP. But as of now, all I can say is there may be a role of
CRP more than 75 has been quoted in certain,
that's what I'm saying, that these are all based on a few studies. Yeah, these are all based on a few studies. CRP has been found to correlate with IL-6 levels, but we must remember there are a lot of pitfalls with CRP. And so that should not be the only marker. CRP can go up with infections, and all these needs to be kept in mind when we're looking at patients.
And thank you. The second question is, the patient is not improving, kind of deteriorating, then it could be a kind of a cytokine storm or hyperinflammation. On the other hand, it could be a secondary infection setting in.
Yes. It's very difficult to say. Yes. And as a clinician at the bedside who needs to take a very conscious decision as to whether it is safe to give tocilizumab or not, I must tell you honestly, in Vellore here in CMC, we managed over 800 patients in the ICU. Our mortality has been overall 25 to 30%, and we have used tocilizumab in 2 patients. That's all we have used tocilizumab in. The second patient who's given tocilizumab is on ECMO right now, and the first patient died. So
can I ask you a question, Dr. Tapesh, if it is?
Yes, ma'am.
Yeah. Dr. Chacko, actually, just a quick question for you for just the last slide that we casted for the NIH recommendations. I think that's one we need to clarify to all the fellow doctors and the trainees, because most of the trials that we have discussed so far, you have very frail or weak recommendations for use of tocilizumab. And but that is the latest, revelation from NIH in support of tocilizumab.
Yeah.
Actually, I've heard a couple of clinicians now quoting that statement for using tocilizumab. But I think we need to understand the strength of the grade of evidence, the strength of recommendation, which is still quite poor.
Which is shady. I would say that the strength of evidence is shady, and clinicians need to take a very conscious, careful decision, maybe even like a combined group discussion to find out whether this patient can be given tocilizumab or not. I would say that if you see when you do a meta-analysis, you need to pool together studies which have similar groups of patients. In the 6 RCTs, I didn't present all of them, but you can see that in some RCTs, the patients were just having moderate illness, not ventilated. Some were who've just gotten to ICU or severe illness. So combining all of them and then commenting on a result is difficult. So I would say, yes, maybe keep it in mind. It may be considered in patients who have rapid respiratory decompensation, but don't jump and use it for every patient is my suggestion. And I'll put a summary slide just after this also for the trainees. Can I carry on?
Yes, please, ma'am. Thank you.
Okay. So there's been a lot of interest in the role of antithrombotic therapy for patients with COVID-19. And this is based on the evidence which has shown that 1 in 3 patients in critically ill COVID can have thrombotic events. It's very interesting, the number of trials that are ongoing. There are 33 ongoing trials just in ICU. So this is a very beautiful article which is written in JACC, and has put up all the articles which are done in not just critically ill, but all the patients with COVID-19. And this is only critically ill patients, and so many trials which are ongoing, and we're still awaiting a lot of the results. But there's a preliminary report from the ACTIV-4, REMAP-CAP, and the ATTACK trials, which have said that in critically ill patients, the harm, that is the risk of bleeding, may be more than the benefit. And they are not recommending, and based on this, but we still need to see the entire study and analyze it before making a definite conclusion. But this is based on the author's preliminary result release. But they have also said that in patients with moderately ill patients with COVID, it may decrease ventilatory and organ support. So there's a lot of people who still are giving therapeutic anticoagulation. In fact, we do the same here in Vellore. We are actually giving therapeutic anticoagulation to all patients who have a D-dimer more than 1,000. honestly speaking, we've had very maybe one handful of side effects or major bleeds also very few, minor bleeds more than major bleeds. But let's wait for the full trial to come out. In short, in summary, I think the basic gist which we can take in patients who are moderately ill, when they come in relatively early to the ICU, you can consider using therapeutic anticoagulation. But patients who are critically ill, too far gone, probably the only thing which will help will be supportive therapy. So I'll just summarize what I've said so far, because I've presented a lot of trials. So please consider dexamethasone for all patients with COVID-associated acute respiratory failure. Remdesivir, better to start it early when they are on low flow oxygen. Don't start it too late. It may not have any benefit then. And the benefit is in terms of time to recovery. Tocilizumab in critically ill patients, I would say more evidence is needed. But as per the NIH recommendation, there may be a role in rapid deterioration, but please make sure that your patients do not have any active infection or any other contraindication for using tocilizumab. And again, there may be a role for therapeutic anticoagulation in patients who are moderately ill, but we need to await and see the full details of the multiple trials which are ongoing for therapeutic anticoagulation in COVID-19. So that's all I'm going to say about COVID-19. And then my next thing is actually going on to the non-COVID literature.
Can we just 2 minutes have a break? If there are any questions, are there? No. Okay. Can we just take a break, ma'am? 1 minute?
Yeah, sure.
Because that will kind of give it a
Sure.
Babu, any comments, sir?
No, not really, but I think Melina has covered a big topic very quickly in a short time. Very well done. But just one or two comments. I agree with Melina that the only good evidence is only for dexamethasone, not for any other steroids. Even though we see people using huge doses of methylprednisolone, I don't think it should be done. It's only dexamethasone. One. Second, remdesivir we used early if the patient is on oxygen and not when they are not needing oxygen. The problem is defining early. So whenever the patient comes into the hospital, even if it is the 14th day, they'll say, oh, maybe we should remdesivir work. So is it 5 days, 7 days, 10 days? It's usually patients become hypoxic in the second week, 10th day, 11th day. So and patients, because of the University of WhatsApp, all know about remdesivir, all know about toci, and they start demanding for it. So it becomes a bit difficult to convince them, saying no, it is not time. That's one. Toci, again, if patients are not improving with steroids, give toci is what now is happening. The problem is, again, when patients come in late into the second week, and when you give toci, what we are seeing is they don't improve, they get intubated. A lot of patients die with severe sepsis. So even though toci might have very low evidence at this point of time, people are using it. And in our situation, I think more of them are going to die from secondary sepsis. That's the feeling I get. Only time will tell. I do not know what the other panelists feel. We as doctors want to give something for our patients. I think we are doing more harm by using drugs that we do not know about, because as Melina is showing, the cytokine storm in COVID is really not a storm. It's just a mild breeze, and we are going crazy with blocking one cytokine. And last 20-25 years for treating sepsis, blocking one cytokine has never helped. And anticoagulation, again, like I agree with Melina, maybe early might help. Late, when they are sick, we have to use it with caution.
Okay.
These are just mainly comments.
Regarding anticoagulation, I would just make a comment that we have treated close to 250 cases in ICU, and for almost all cases we used almost therapeutic anticoagulation, or at least the DVT dose of anticoagulation. And we didn't find that much bleeding incidences, which could be attributed really to this low molecular heparin or standard heparin. So given the physiological basis of this disease, those postmortem findings, I think thromboprophylaxis or giving anticoagulation to severe ARDS patients in a balanced manner, of course, checking their coagulation profile and platelets count have helped these patients. I am not aware of much literature which actually points towards increased bleeding incidences from such uses of anticoagulation in COVID ARDS cases.
I think it's just this recent ones
Yeah.
and the preliminary data from the authors.
No,
That is the thing which where they have suggested more harm than benefit. But what you're saying, Dr. Sharmili, is exactly what we are seeing here. We are hardly seeing any bleeding.
Right.
And all our patients are therapeutic anticoagulation. 800 and probably maybe 4 or 5 would have had a major bleed which required transfusion, which is a small amount compared. Probably, I feel many of the Western studies included their patients are much older, 70, 80 years. Our patients, at least the ones we are seeing here, are in 60s, 60 to 70s. They're not that old and probably not as fragile as the population abroad. That is my feeling. And so we'll have to look at it, keeping in mind all those things. So the message
I
to
think
the
when the
trainees
statistics actually reveal the kind of data and the patient profiles, demographics, that will be more clear.
That will be clearer. That's true.
Exactly. Yeah, I'll just make a couple of comments. I agree with Sir Babu sir that TOSI is being overused, and like Dr. Binilla very nicely showed all the studies, there is very weak evidence and very carefully and selecting the patient if at all. And it's definitely going to cause a lot of harm, and it is causing a lot of harm. Then regarding the early use of REM and the late use of DEXA, you use REM early and you use DEXA late. Why is that so? So that is because just for the trainees understanding the disease, initially the viral replication is causing the problem in the patient, and the viral replication goes on for 1 to 2 weeks. So that is the reason why REM has to be used early. After that 1 or 2 weeks, the viral replication stops, and it is the immune response, the cytokine response, and the hyperinflammatory response which takes over. So that is where your Dexona comes in, right? So that is the rationale behind early use of REM and later use of Dexona, and Dexona in those patients who get severely ill. Otherwise, it does not really help because it has immunosuppressive effects also. Dexona also is an immunosuppressant of sorts, depending on the dose and whatever type you are using. So that is the rationale. Then the other thing is about coagulation. Ma'am, just like to add that initially it was like give higher dose and all, but there is some evidence emerging where maybe there's a difference, ethnic difference, that you should not go beyond 0.6 of Clexin because that is what the emerging data is, that probably they can bleed also. Earlier it was that we can go to like a higher dose 0.6 BD or 0.4 BD, but it is still emerging like you just said. So, and the third thing is to differentiate, when the patient is deteriorating from an infection setting in, and whether there's a cytokine storm, so-called cytokine storm, which has also lost flag now, because initially it was all cytokine storm, which is just the hype now, because cytokine storm can occur anywhere. Even sepsis is a kind of cytokine storm. When the patient goes into multi-organ failure, that is also a kind of cytokine storm. So here probably one has to look clinically at what is happening, but Procal might help. Because if you follow the Procal, initially Procal does not rise classically in these patients, and when you get a sudden rise in Procal, you can probably think that's an infection setting in rather than a cytokine storm. Because classically, cytokine storm associated with the worsening in COVID, you don't get a elevation of Procal, but you will get an elevation of CRP. So just what I wanted to add.
Interestingly, Dr. Tapesh, actually here somehow with COVID, there's something else which we're looking at is we are not actually seeing Procal go up even in patients who are bacteremic, which is a very funny thing. I'm not sure what exactly is happening. I think we still there's still a lot of gray areas in COVID where we don't have the answers, and we need to make wait for some more literature to come out. A lot of unanswered questions, but I would say the bottom line is good supportive care for all COVID-19 patients, dexamethasone for all COVID-19 patients, remdesivir start early. There are a lot of questions in the chat box on various drugs. I think Dr. Sharmili said she'll be, will you be covering ivermectin?
Covering plasma. There was some question on ivermectin and cosprin or NOACs, newer anticoagulants and discharge. So are you going, you'll be covering in your next talks, or we can take this question?
Ma'am, one minute, ma'am. Dr. Jacko, you want to take the question or you want to continue? With the
I think I'll carry on because
Yes, yes.
maybe for the trainees, those aspects on ivermectin and antibiotics, the evidence is there is a physiological basis as to why all these antibiotics, ivermectin, azithromycin, colchicine, everything, there's a physiological basis, but there is not enough evidence as of now to support it. It's not a drug which has side effects, but people do say tocilizumab, if there is, especially since you mentioned ivermectin, strongyloidosis, if you suspect strongyloid infection, must treat with ivermectin before giving tocilizumab. That is one of the recommendations that are given. So I'll just move on to the non-COVID literature. And just 1 second. Yeah.
There's
Okay.
a question on formulation
I was wondering how to actually cover 10 studies.
Carry on,
I think that will be covered by, that will be covered by Dr. Sharmili, plasma therapy.
Yes, okay, please carry on.
Yeah, okay. So non-COVID 10 articles and to keep everyone's interest very, very challenging. So I thought I just went through, I've gone through it in a system-wise approach. Interestingly, a lot of similar articles. So I thought I'll start off with the respiratory system and look at the trials which have come out, which are of interest. So there was the LOCO trial, which came out in NEJM March 2020, which was liberal versus conservative oxygen therapy. And by this was the definition that they used. They had low oxygenation group, which is a PaO2 of 55 to 70, or a saturation of 88 to 92. Higher oxygenation group, where the PaO2 was 90 to 105, SATs of more than 96 was what this study looked at. And the sample size, which they originally planned for, was 805. But you can see that the study was stopped early. Only 205 patients were randomized into conservative and liberal arm. And this was the amount of oxygen that was used. Obviously, understandably, it was more in the liberal arm, and the SATs were understandably higher than the liberal oxygen. If you look at the primary outcome, that was 28-day mortality, there was no difference in the 28-day mortality. But what they did observe, and this is one of the reasons why the trial was stopped early, the 90-day mortality appeared to be higher in the conservative arm, with more mesenteric ischemia in the conservative arm, and the trial was stopped early. But this was some of the reasons why the study was criticized, because it didn't reach its original sample size and hence may be underpowered to make these kind of conclusions. Similarly, now, one thing about ICU studies is there are a lot of acronyms. So for the trainees, it sometimes makes it easier to remember, sometimes makes it much harder if your examiner asks you in terms of what is the hot ICU study results. So this also looked at very similar strategies, lower versus higher oxygen therapy, but this was in ARDS, this was in all acute hypoxemic respiratory failure. The hot ICU was in all acute hypoxemic respiratory failure. Here again, the lower oxygenation group had a PaO2 of 60, higher oxygenation group PaO2 more than 90. This is a much larger study. So close to 3,000 patients were randomized. You can see here that the SATs in the lower oxygenation group was probably between 92 to 94, as opposed to the higher oxygenation group where the SATs were more than 96. The primary outcome in this group was 90-day mortality. So here again, as we mentioned in the LOCO trial, they found that the 90-day mortality was higher in the conservative arm. Trial stopped early, but in this study, the study was powered to look at 90-day mortality, and they found no difference in outcomes in terms of mortality, ventilator-free days, and adverse events. So the conclusion that you need to take for these trials is there is no harm in giving. Our standard ICU protocol is to keep a saturation of 90 to 94%. And that is probably what you need to continue doing based on the results of this very large hot ICU study. Then this was another study which came out, which is looking at protocolized post-extubation respiratory support to prevent reintubation, or this was called the PROPER study. Now, what this looked at was randomizing patients to getting either high flow nasal and NIV versus standard of care. This was what most patients actually were put on high flow nasal cannula. NIV was used only if they had a type 2 respiratory failure. Rescue therapy, you can see here that within 96 hours of extubation, both the protocolized support group and the usual care group, both of them ended up using almost similar amounts of HFNC and NIV therapy, and there was no difference between both the arms. Their outcome that they were looking at was reintubation within 96 hours of extubation. Okay, that was the outcome that they were looking at. And what they found is there was no difference in the reintubation rate between the protocolized support or usual care. So finally, again, conclusion from this study is do what you're doing. You don't have to put all patients on NIV and HFNC. There is no evidence to support that. This is a fairly big study, close to 700 patients, which were randomized, and there's no evidence that protocolized post-extubation respiratory support prevents reintubation. This is now moving on from the respiratory system to the heart. This is called this is a nice acronym which I found, ECMO or ECNO for refractory cardiac arrest. This was the ARREST study, which was published in Lancet, which actually looked at which included patients out of hospital cardiac arrest, either VF or VT, who didn't have return of spontaneous support circulation after 3 shocks, and who were able to reach the ED within 30 minutes of the arrest. And they declared a patient dead if the ETCO2 was less than 10, PO2 or SATs was less than 85%, and the lactates were more than 18. What they did in this study was they compared ECMO 15 patients versus standard ACLS 15 patients, both of whom, you know, if they managed to put them on ECMO or they recovered, they would take them straight to the cath lab and do catheterization, PCI. And the primary outcome was survival to hospital discharge. Secondary outcome was survival at 3 months, 6 months, and favorable status of cerebral performance category of 2 or less. And what you can see here is the ECMO group, 6 patients survived to hospital discharge as opposed to 1 patient in the standard ACLS group. And in the ECMO group, again, you can see here that they had better cerebral performance category score as opposed to the arm which would receive the standard ACLS. So if your hospital is capable of putting patients on peripheral VA ECMO or, you know, in the ECMO CPR, I think it's a good thing to look, because this is, even though it's a small study, it's not easy to recruit 15 patients into a post-cardiac arrest study. So this study does show evidence of benefit of ECMO if it's used within half an hour of the arrest. Another study was which I've looked at is looking at the MAP targets for geriatric patients, where they looked at patients more than 65 who were randomized to receiving vasopressor therapy after having received adequate fluid resuscitation. The MAP target was 60 to 65. We all know that high versus low MAP, there is evidence to suggest that there is no benefit of keeping a high MAP. So here they've looked at an even lower MAP for patients who are geriatric, 60 to 65, outcomes for all-cause mortality at 90 days, and secondary outcomes for ICU hospital mortality, duration of survival, ventilator-free days, dialysis-free days, and length of ICU. And you can see here, most of the patients were close to 75 years and received similar amounts of, you know, norepinephrine, epinephrine, vasopressin, and 50% actually received more than 0.1 mics per kilogram per minute of norepinephrine equivalent dose. What we can see here, there is no difference in the primary outcome, which is 90 day all-cause mortality. And even more interestingly, because we're always concerned, will there be a compromise in organ perfusion? There was no difference in primary outcomes or organ failure or need for organ support. So it may be okay to target lower MAPs in the elderly population. Moving on to 2 interesting renal studies. There was the START AKI study, which looked at initiating patients with stage 2 or stage 3 AKI on early versus standard strategy. So standard strategy is initiating dialysis only when there is an indication for that. This was a huge study, close to 3,000 patients. The primary outcome was 90-day mortality. And we can see here that, again, here, there was no difference in the primary outcome of 90-day mortality. But I just want to highlight one thing here, is the death or RRT dependence at 90 days was actually slightly higher in the group who were on the accelerated strategy. That means as soon as they were diagnosed to have stage 2, stage 3 AKI, they were initiated on dialysis. Then there was another study which is called the Acute study, which actually compared 2 delayed strategies for renal replacement therapy. Again, here, this was the KDIGO stage 3, and delayed was diagnosed as like within 72 hours of oliguria. That was called delayed initiation. More delayed strategy was where it was initiated after 72 hours until there was a mandatory indication. And the primary outcome was alive and RRT-free days. And we can see here again, there was no difference actually in primary outcomes or in organ failure. So the bottom line from these two renal studies, big studies, which looked at early or late or mandatory, is that you start dialysis in ICU when indicated by standard criteria. Just two studies on the liver also. There's the Attire study, which looked at albumin infusions in patients with cirrhosis, where patients with decompensated cirrhosis were included in the study and expected to stay for 5 days. Albumin was given for 14 days, close to 700 patients in this study, and the composite of infection from any cause, kidney dysfunction, or death was their outcome. And again, here they found no difference, but more serious adverse events in the albumin arm in terms of pulmonary edema and fluid overload. Terlipressin plus albumin, we all know that terlipressin has been shown and has been put in the guidelines as evidence, but this as recommended for type 1 hepatorenal syndrome, but this has not been proven in a major RCT. So this study was, or the confirmed study, actually looked at putting patients on terlipressin and albumin for type 1 HRS and looking at the outcomes. So this was close to 700 patients. Outcome was resolution of hepatorenal syndrome and RRT-free days. And what they actually found was that terlipressin and albumin fared better than placebo and albumin. And this supports that, yes, you can use terlipressin in patients with type 1 HRS. But remember that this study also found that there were more serious adverse events in terms of in the terlipressin arm, because terlipressin is a vasoconstrictor. And so patients who've got advanced hepatopulmonary syndrome, high pulmonary artery pressures, you'll probably have to be cautious in using terlipressin in that group. The last two studies which I'm dealing with are the ATTEST study. This is based on the metabolic therapy, which is recommended for sepsis, which looked at vitamin C and thiamine, vitamin C in the dose of 50 mg per kg, thiamine 200 mg, given 12th hourly versus placebo. The outcome was a change in SOFA, and secondary outcomes to ICU hospital mortality, ventilator free days, vasopressor free days, no difference in outcome. So this study, this was a smallish study, only about 100 patients, found no evidence of benefit. This was a much bigger study called the Victa study, which looked at very similar combination of vitamin C, thiamine, and hydrocortisone in a group of patients with sepsis. The study sample size was 2,000 patients, and they looked at 1.5 grams of vitamin C, thiamine 100 milligrams, hydrocortisone 50 milligrams given Q6 hourly. So this was given 6 hourly versus placebo. Now, this study sample size was 2,000, but they actually only went on to recruit only 500 patients. And the primary outcome was vasopressor and ventilator free days at day 30. And secondary outcomes was very similar to the outcomes in the ATTEST study. And what they found again was that there was no difference, no evidence of benefit. So there's no data to support the routine use of vitamin C, thiamine, and hydrocortisone in patients with sepsis. The study was stopped in this because of early funding issues. So the take-home points for the non-COVID trials, what's out is protocolized extubation support. Albumin in acute decompensated liver failure is not useful, may be harmful, and may cause more fluid overload. There's no role for accelerated or keeping dialysis delayed. Just because you want to dialyze, you dialyze. There's no role for metabolic therapy in sepsis. What's in is you continue maintaining all your patients in ICU on a SATs of 92 to 94%. There's possible role of VA ECMO in patients who reach hospital within 30 minutes in an out of hospital cardiac arrest. Older patients, you may be able to target a MAP of 60 to 65, and the role of terlipressin is confirmed in patients with hepatorenal syndrome, but be cautious in patients who've got advanced hepatopulmonary syndrome because it has been shown to worsen respiratory failure. So that's it. This is our team, and just part of our team, faculty team, and some of the registrars in ICU. We've got a good going COVID right now. It's quite bad at this point of time. A lot of patients on the waiting list. So I'm sure many people are facing similar situations right now. So I'll stop right now. That's all I have to say, Dr. Tapesh.
Dr. Binilla, wonderful slides, first of all, and a lot of hard work in those slides because it takes a lot of effort to make those slides, and I've spent a lot of time reviewing everything. So my thanks to you. And that was a wonderful review of the year 2020. I think practically all the important things and the latest on TOSI. So that was lovely. But just a request, ma'am, can we just have the second last slide? All the trials, so the panel can kind of have any comments, they can make their comments, what they want to say anything about that. The last, when you summarize the slides, the summary. Yeah, this one.
Okay, can you see?
Yeah. And guys, you have any questions, please put them, Doctor, because after that, Dr. Binilla will be leaving. She has, like, she's very busy with some ECMO patients, so she is requested to leave. So if we have 5-10 minutes, please put the questions. But Dr. Sharmili ma'am, you want to comment on any of the trials?
I think a lot of information has been put, and it's all that she could encompass all the trials, recent trial. And I like that she used the word last financial year, because when you proposed that we pick up top papers of 2020, I thought it was calendar year December 2020, but I think she has been clever and wise enough to cover most of the trials till end of this financial year. Only one question regarding this VA ECMO CPR mortality. I think it is just very few patients have been looked at, and it's a big actually conclusion to think that ECMO should be advocated for early institution in patients with out of hospital cardiac arrest, because in real life scenarios in across different countries, ECMO is an expensive affair, and getting patients who had out of hospital cardiac arrest, putting them right away on ECMO is a challenging task. So I think we need more number of patients and be more data to accept this fact that ECMO could be better than just ACLS. I think for the timing, we should still continue to emphasize on proper ACLS.
Yeah, definitely ACLS should be there. And I mean, given our ambulance situation and our roads and the traffic, I don't think any patient in India will reach hospital within half an hour of a cardiac arrest. So this is probably, I just put it in for the trainee's sake, in the sense that just for them to be aware that this is a trial which has been published. It's interesting. And patients, like if you have someone who reaches you early, in fact, we've tried to do it for a few patients here, but it is very challenging. It's not easy. And as you said, cost comes in.
I'm not sure which center is this. It must be an ECMO center. Definitely. And as it happened in 2010 about that first ECMO, I forget the name of the trial about VV ECMO for ARDS cases. Caesar trial, right. So similar center must be that ECMO center. And about older critically ill patients, targeting a MAP of 60-65. I think there is a catchment here also for patients who have been long chronic hypertensives with there is a phenomenon called autonomic resetting. It does happen, and actually patients who have been like elderly in the ranges of 150 to 170 systolic, and if they get sepsis and the MAP comes down to 60 to 65, I would say probably it will be little different from those chronic hypertensives, targeting a MAP of 60 to 65. As we say most often that one size doesn't fit all. So in those cases, actually, it would be prudent to keep a higher MAP between around 80 to 85. But nevertheless, our target is microcirculation. So if the lactate is remaining normal, end organ perfusion is remaining fine, which is the best to be assessed by clinical assessment. I think MAP is just another number.
Exactly. I think that's what I always tell my registrars. MAP is a dynamic target, but sometimes we set the target as 80, and without looking at anything else, the patient may be pouring out urine, maybe lactate may be low, but you somehow you give inotropes or vasopressor support to reach that target. So I think this study helps us rethink, saying yes, we may not need to do that, but what you said is very important. Target to end organ perfusion, target to microcirculation. That is the bottom line. And keep relooking at the patient. Don't just blindly set a target and walk away. Come back, reassess, see whether you can lower the target, see whether you can use less vasopressive supports for patients, for all patients, in fact, not just older critically ill patients, but all patients. Yeah.
Actually, a MAP or a systolic pressure of 80 is okay for your CLD patients, which you have shown 2 trials. They perfuse well even with a systolic pressure of 80-85, because they have so much vasodilatation. So, Dr. Sharmili, ma'am, any other comments, or should we ask Dr. Babu to?
Melina, can you put back your last slide? It's only for comments. When you're called a panelist, you think you can sit and give your comments and not actually talk evidence. Thank you. So, my comments basically are protocolized. Any protocolized study that the Western world shows, I think in India we have to see whether it works, because I burned my hand, my whole body, I would say, not my fingers, by trying and putting a protocolized Western protocol into ICU. it was as simple as an insulin protocol, and our nurses could not understand the English in it, and the whole protocol just did not work. So when we say protocol, any protocolized work from the Western world, please use with a pinch of salt when you use it in India, because maybe it will not work. Albumin works only in Australia because it's cheap. It doesn't work anywhere else. I don't think albumin has any role anywhere other than increasing the cost, and we have to be very selective in using albumin in our resuscitation, because cost is a big issue here. This is always an ongoing debate. Dialysis, and it has never been shown that starting dialysis early ever works. Here, only Merrick has found the benefit, vitamin C and thiamine. Nobody else has been shown Merrick with this very few cases. Okay, so I think you have picked up a few good studies and highlighted the point. Now, again, oxygen. I wanted to just comment on something. I think oxygen is being misused. And I think one of the reasons that we are seeing a lot of lung damage in COVID patients is because of our misuse of oxygen. We are leaving patients on oxygen for a very long time, on high oxygen, not supporting lung early. And I think that's adding on to the long-term lung damage we are seeing. And this clearly shows that we need not use high oxygen to maintain higher saturation. 90 is very good. VA ECMO, as Sharmili was saying, it works if you have the expertise. Not every hospital should try, just because of the study, try to use ECMO, because ECMO works if you have the expertise. You have done large numbers of ECMO, it works. Otherwise, it's very expensive not to be tried. I agree completely with the panel that MAP is just one of the targets, and you have to look at the whole patient as a whole and not just target the MAP. But it's very nice study, very nice conclusion from the study saying that even in elderly, you need not drive a MAP to say 85 just because they had hypertension, as long as all the other organs are being perfused and lactate, and overall the patient looks okay. And 30%, the study confirms that 30% works in HRS1. Okay, only thing that's nice that you highlighted that people with hepatopulmonary syndrome, maybe we should keep an eye on that. Fine, that's a good take-home message. And as
I have to add, just sorry, you carry on.
You've done the 10 studies. You have done extremely well. Thanks, Vilna. We have covered it very well. Thank you.
Yeah, I have only one point to say, mention about this dialysis. Actually, regarding the initiation of dialysis has been long going on, and n number of studies, of different sort of acronyms have been in place. But I think trainees get confused many times when to start dialysis.
Correct.
I think the age-old teaching which were taught during our MBBS days still stand. Like those 5 indications of life-threatening acidosis, hyperkalemia, fluid overload, or very high urea creatinine. And those are the ones, I think that should be still followed. And nonetheless, I mean, how many trials have come and gone, but nothing have actually clearly answered these questions of where either early or late dialysis, and what is early and what is late, what is accelerated and what is delayed. It remains to be solved. So I think those 5 clinical criteria which must continue to follow.
Yeah, absolutely. So thank you, Dr. Sharmili and Dr. Bowser, for your comments. So I just like to the only thing is that saturation, I think, is it 92 to 94 or 92 to 96, Dr. Binilla? I think it's 92 to 96. I mean, whatever.
92 to 94 is what the studies did, and more than 96 was the other group.
Yeah, okay. So the thing is, hyperoxia should be avoided. That is the thing which is emerging, that you should try and, kind of keep it less than 96%, because hyperoxia in sick patients has been found to be harmful. The oxygen molecule is supposed to be damaging, causing oxidative stress to the tissues if you go beyond 96, which was the trend till a couple of years back. But now people are realizing not to, keep the saturation 9900. So that is one thing we should realize, keep it down, keep it less than 96, and also do not let it go below 92, because there are inadvertent periods of hypoxia. Your pulse ox is not there all the time. So the pulse ox is coming out, and sometimes there is dipping. So those things are also very important. So 92 to 96 or 94, I mean, whatever. So hyperoxia and saturation less than 92 should be avoided. So this is one thing which is emerging, and one positive thing which has emerged, which is rationale. The other things are by and large the same. For example, terlipressin. Terlipressin was always there, and a very sound rationale that in HRS, the primary pathophysiology lies in the splanchnic gross vasodilatation. And as compared to vasopressin and your noradrenaline, terlipressin is a very strong of the splanchnic circulation, and thereby improves your systemic circulation and your renal flow. So that was the logic behind terlipressin. Then coming to MAP of 60-65, when MAP has to be targeted through the flow, and then you come to the accelerated dialysis. Like I said, there's a lot of confusion of what is early. Can you please?
Please, the audience,
So-
please mute yourself except the speaker. Please all mute yourself
Dr.
except the speaker.
Ansari, I think it's Dr. Ansari's mic is on.
Okay, Dr. Ansari is there. And he joined. Okay, Dr. Ansari, hi. So accelerated and delayed dialysis. Well, delayed dialysis is the classic dialysis indication, like ma'am said, blood urea of more than 200, potassium of more than 6, acidosis 7.15, pericarditis, encephalopathy, gastric bleeding. The problem with early dialysis is twofold. One, procedures. Okay, you put in the lines, this, that, you get sepsis. Second is it removes the antibiotics. One of the things, problem with modality in AKI, especially with sepsis, it has a very high mortality, we know, is you do not know your antibiotic levels. And when you start doing the dialysis early, you compound the problem. That's one of the problems here. And then finally, coming to the first two trials, albumin in acute decomposition renal failure, again, it's been proven thing. So we don't get anything new. There are only 3 indications to give albumin in liver disease patients: SBP, HRS, and large volume paracentesis. If you have sepsis, then it can be given as per sepsis 3 guidelines. After giving fluids, you may give some albumin. And please remember, albumin is not a volume expander. Actually, it's more of a drug in liver patients. It's a very potent drug having multiple functions. But these remain the indications, and they have been proven for many years now, practically. And coming to protocolized extubation support, there is a tendency for our younger people to extubate the patient and put them on NIV. Please remember, do not extubate unless the weaning criteria is met. And only in those difficult cases who are not coming out, whom you want to take a chance, there only you should extubate them and put them on flow or NIV. And even for your COPD patients, there's a trend to ventilate them for 24 to 48 hours. Without a trial, you put them on NIV. That again is not totally correct. You have a wider margin in COPD patients that they will do well compared to a hypoxic failure after you extubate them and put them on NIV. But even they have to be given a trial, because sometimes they don't do well on a trial. If they start sweating and go on your TPs or whatever, then you cannot extubate them. So this is what I would like to say. And again, I would like to just congratulate Dr. Binilla for and thank her for the effort and the beautiful slides. Slides were really refreshing. Thank you, ma'am. Thank you so much. And
thank you, Dr. Tapesh. I think it's refreshing to know that we've not been doing many things wrong over the past few years. These trials coming out, this is what we practice every other day, and we just continue to practice that and do sensible medicine. That's the logical medicine. That's the key take-home message. So I'll stop sharing now.
Yeah, Dr. Ansari, hi. So,
yeah, hi. Sorry for apologies for the delay. I could join right now.
Yeah. So we'll carry on. What you just joined, or you want to make any comments, or you want to see the next session now?
No. We just continue. I'm just there.
Okay. One question has come up. 1 minute. A couple of questions are there. How? I think they are all answered. Huh? There's nothing there.
There was a question on prescribing aspirin or NOAC, neuroanticoagulants, or discharge for COVID pneumonia patients. Would you like to take it, anyone? Or
I mean, there are ongoing trials which are looking at this. As I mentioned, that article which I showed you from JACC has covered the numerous articles looking at these aspects, ecosprin, NOAC. As of now, I think we just have to wait for the evidence to come in. Patients who need aspirin, give them aspirin. There is some suggestion to say that in COVID, there are platelet-rich thrombi. So some people are prescribing aspirin for patients in ICU, but we have to wait for the evidence for all these anticoagulation and antiplatelet trials to come out.
NOACs? NOACs.
Similarly for both. I think for both, I would request the trainees to read that trial. I can send it to Dr. Tapesh, maybe he can forward it to the others.
So I agree with you regarding use of aspirin. Regarding NOACs for all, I would like to share one thing. Only we are using therapeutic almost anticoagulation or maximum up to limiting up to 0.6 ml of low molecular heparin for severe COVID patients on ventilator or high oxygen therapy. But for patients who have documented evidence of deviant thrombosis or pulmonary embolism, as we normally follow the protocol for up to 3 months or 6 months, depending on the manifestation of the severity of the embolism, we should continue to do that. If there is evidence of DVT or PE, we should continue. We can switch over to the DOACs or NOACs for up to 3 months or 6 months, subject to follow. And regarding aspirin, I think it is if most of there is comorbidities like hypertension, diabetes, or coronary artery disease. Those are the cases people are usually on antiplatelets that could be continuing to the community at the time of discharge. There's a question on use of ivermectin or colchicine. Colchicine, I think, it's taken a back seat. It was initially just used at a couple of places, but not been talked about at all after that. But regarding ivermectin, actually, I think there has been huge usage of this drug in the later half of the pandemic in India and many of the Asia Pacific countries. And still it is continuing. It came in recommendation of a few of the state governments as well. And people have been using it off label at the community level as well. I am not aware of any good paper on the usage or the efficacy of ivermectin for either prophylaxis or treatment. But I think we must admit that there have been a lot of usage of this drug going on at community level. People, the Google doctors and WhatsApp University, they all recommend this and people use this drug quite often. I think that's one from the questions from the, there is a question on kappa in COVID. I didn't understand the full form of kappa. What is kappa?
Oh, that's COVID-associated pulmonary aspergillus.
Aspergillosis. Oh, okay.
That is another thing which is coming up. Everyone gets voriconazole, everyone gets ivermectin, everyone gets okay. I don't know.
Pulmonary aspergillosis with COVID, I think, with more uses of steroids. It has been quite of bit of case reports or case series on this have been published, I believe. And many places are actually, the doctors are actually advocating prophylactic use of voriconazole or amphotericin for these cases, but something that I would not agree with. I think keep vigilance, keep your eyes and ears open, clinical signs at the bedside, exercise that. But it's not so common in my practice. You can share your experience, senior doctors, Dr. Abraham and Dr. Chacko.
See, it depends on the ID physicians because a lot of them are doing now the Aspergillus galactomannan test widely, and if it is mildly raised, they have a very low threshold for using voriconazole, which is I personally feel which is unwarranted. Now, talking about steroids, 6 milligrams of dexamethasone, if you convert it, would be at about 200 to 300 milligrams of hydrocortisone. And that's what we have been using in our hypotensive septic patients for the last 20 years. We never saw any aspergillus hyperinfection. We didn't see pulmonary aspergillus. How come all of a sudden all this have popped up? That's my only concern. I think there's a lot of misuse without actual evidence as of now. I don't think there is strong evidence unless there is you look for aspergillus, you find aspergillus, then maybe yes. Melina, what is happening in CMC? Are your ID physicians using?
No, we're not using it's available, the test is available, but one of the standing instructions is aspergillosis, diagnosing or confirming the diagnosis of aspergillosis is based on a biopsy. And you need to see evidence of invasion. And so in our cohort of 800 or 850 patients who've come in, I honestly haven't seen a single patient with aspergillosis till now. I don't know whether it's because our population is different or what, but I think, as you mentioned, Dr. Sharmili, I think it's mostly case reports, case series, and based on that, we should not react. Correct. I think in COVID, the mistake which has been happening is people have been reacting to small reports. It's not hard evidence, and that's where all the hydroxychloroquine, starting off from there, the story has gone on, and multiple agents have been tried in this disease. So many publications, so many reports. I'm sure at the end of this second season or part 2 season, COVID season 2 is what we call it here. At the end of this COVID season 2, we'll probably be back to giving good supportive therapy and nothing more than that.
Exactly.
Yeah.
Only one thing is that probably we
Dr.
have
Babu,
seeing more of this Candida infections. The fungal infections are more, but it's not particularly aspergillosis. But Candida, different non-albicans species have been more increasingly being isolated. We had 5 Candida auris in the last season, actually.
Correct. I think as we, as we support and prolong life, we are going to see that we are using higher end antibiotics and you prolong life. If people die early, you won't see it. If you prolong life, you are going to see this super infections with Candida and all that. That's what I think. I don't think it is more than what we were seeing before, but now because we have a larger number of patients who are ventilated, we think that we are seeing more. I think proportion wise, I don't think Candida or Aspergillus. We have seen few mucor after TOSI. Before the wave, when the first wave, there were a lot of misuse of TOSI, and after that, patients coming back with mucor. We had about 5 patients of mucor, lung, sinuses, and cerebral mucor. About 5 patients we had. That's in the tertiary said I do not know how much Vellore is saying, where they will see much more patients than what we are seeing.
So actually, the dose of Dexa, people are using much higher. That's a problem. That's why there's more aspergillosis. The strongest risk factor for aspergillosis is actually steroids, and people are going to up to 24 milligram per day also. So probably there is some aspergillosis. That's what I've heard also. There is some aspergillosis.
No, yeah, but
TOSI is causing mucor, or you're getting aspergillosis with high dose, and even TOSI would predispose to some aspergillosis. But
no, I think if you have used TOSI, we should have a higher threshold for looking for other infections. That's all, and not start medications as prophylactic. That's my only thing. Do not start voriconazole prophylactically, or have a higher threshold and look for it.
And use very little, sir. If you can convince the family, and if you are convinced, then don't use it, I would say. The first dictum would be do no harm, I think. In COVID patients, apart from REM, early REM and Dexa, definitely, the anticoagulation, the dictum would be do no harm. Or age-old dictum.
Correct. What will you do if there is the health minister calling you up and saying, I've moved the patient here for tocilizumab, I've moved them here for ECMO?
No, that's okay. That's okay. But generally, as you know, for everybody is not seeing health ministers and all. So, for our trainees especially, and for everybody, there's a lot of audience.
So no, the concern is it's the non-medicals who are dictating the treatment, and that's what has happened. Politicians saying that plasma will work, politicians saying that HCQ will work. I think that is what has messed up.
Yes, Dr. Binilla, please.
Yeah, I'll carry on now.
Yeah,
thank you so much.
Thank you.
Thank you. Thank you.
Okay, we'll start with the second session. Dr. Sharmili, ma'am, please. You share your screen, please. And you have to unmute yourself.
Is my screen visible?
Yeah,
Yes,
yeah, you are.
Yeah. So after those high voltage and engaging discussions on so many important trials of 2020 and early part of 2021, I'm on to a very low voltage trial, yet very important. And one of the attendees actually had initially asked a question about role of plasma therapy. So this trial is about Placid trial. It is very much indigenous. It is conducted in India. And one of the reasons that I chose this trial to discuss that we keep on discussing all the time some different papers which are conducted in the different countries outside. And I think this is first time one of the trials that has been conducted in the peak of pandemic time in 2020. And under the best of circumstances, under those challenges. So, just at my screen. So this is a study actually looked at the role of convalescent plasma in the treatment of moderate COVID-19 disease in adults in India. An open label phase 2 multi-center randomized control trial. It involved 39 public and private hospitals. Of these, 29 were public hospitals and 10 private hospitals also participated. The participants were actually around 464 adults who had a moderate COVID-19 disease with an oxygen index between 200 to 300. And the primary outcome which they looked at was progression to severe disease or all-cause mortality at 28 days. This was published in BMJ in the year 2020, October. You can see that inclusion criteria was only for adults who were more than 18 years of age, presenting with a respiratory rate of 24 per minute, PO2 by FiO2 ratio between 200 to 300, or saturation less than 93% on room air, and there was a suitable matched donor was available at the point of enrollment. Patients who were pregnant and lactating mothers were excluded. Those who had severe disease with a PO2 by FiO2 ratio less than 200 were also excluded. Patients who had shock and the patients were already included in other trends, they were also excluded. Anybody known to have allergic or hypersensitivity reaction to plasma or other blood component were also not included. And anybody who had received immunoglobulin in the last 30 days were also excluded. Sorry. So across these 39 centers, around 1,220 patients were found eligible, and of these, 746 were excluded. So only 464 patients were included. Or they were randomized, and the randomization was done actually at the level of the center only. So of these, 235 were allocated to the intervention, that is the convalescent plasma, plus the best standard of care, whichever was accepted and being practiced at that center at that point of time. And 229 were allocated to the control group. So they just received the best of standard of care, whatever the drugs and the organ support therapy recommended by the government and the center. But they did not receive any convalescent plasma. So this table actually is shows the demographics and the clinical and lab findings. Drug treatment, as you see, this study was conducted between April to July 2020, and of that time, hydroxychloroquine was much in use in India. Remdesivir was just coming up. You see, of 235 patients in the intervention arm, only 7 had received that, while in the control group, 13 had received that. So not much higher percentage of usage of remdesivir at that point of time. There were other antivirals were also being used because remdesivir was not being available probably in good quantity at that time. Methylprednisolone was the more popular steroid at that point of time. And where still many research was going on regarding which is the best steroid to use. Dexamethasone is, you see the usage is in less numbers. Toci was also on the lesser number being used because of the cost, and number 2 was its availability. Heparin, if you see, either the standard or the low molecular heparin was being used in large number, almost equal 76 to 74% of patients in both the groups were receiving it. That indicates that anticoagulation was already accepted as one of the treatment modalities early in this pandemic. Azithromycin was also being used in good numbers. IV immunoglobulins, I'm not aware, but only one participant of the intervention had received it. And antibiotics use was really huge, as usually the general practice is for any patients, be it viral or bacterial or both. Antibiotics are actually very popular. So what happened after these patients were enrolled? They were all clinically examined, they were screened, and they were given the appropriate therapy. Blood tests were included, the common hemogram and this renal function test, liver function test. Coagulation profile was sent at a regular interval of 0, 3, 7, and 10 and day 14. Serum markers like ferritin, D-dimers, lactate dehydrogenase, and C-reactive protein was sent for all these patients on day 0, day 3, and day 7 to see how they are reacting to the intervention, that is the convalescent plasma therapy. And you can see this blue one indicates the control arm and the yellow one indicates the intervention arm. So on day 0, all these participants were also actually screened for the presence of any neutralizing antibodies in their serum by the accepted assay methods in their laboratories. And you can see that serum ferritin level at enrollment it was little high, almost equal on day 3. And at the end of day 7, they were almost equal, or there was no significant difference. Similarly, for lactate dehydrogenase also, there is not much difference. C-reactive protein similar, and for D-dimer as well. Actually, from beginning, we have been always wondering, like, what is the role of really getting all the biomarkers done for any COVID patients get admitted? There has been a common trend, which is saying that if all the markers are seen, but I'm really at my and fail to understand that what is the role of markers that actually it never dictates the treatment. It is the clinical condition of the patient which actually decides the treatment and the organ support. So sending all the markers at the outset is actually not a very prudent or wise approach. However, doing a D-dimer level does tell you something about probably the degree of prothrombotic or degree of inflammation to some extent. But that also has failed to show any consistent trend and does not guide or dictate treatment anyway. But those were monitored in this trial. About the neutralizing antibody, you see on the day 0, day 3, and day 7. So there was actually at admissions, they had almost equal level of antibodies. On day 3, it was almost equal. But on day 7, actually, to the contrary, only the standard care group had mounted more level of neutralizing antibody. So neutralizing antibody for those patients who received convalescent plasma therapy actually did not go up, as opposed to our common belief. So what happened? What about this primary and the secondary outcomes? You see the primary outcome, which was the all-cause mortality at 28 days or progression to severe disease. 44 out of 235 in the intervention arm actually had died or progressed to severe disease, compared to 41 in the control arm. So there was no significant difference between both the groups. So the primary end points did not show any significant difference between the two arms. What about the secondary outcomes? Resolution of symptoms on day 7. These 3 top symptoms like shortness of breath, fever, cough, or fatigue. Among this, shortness of breath and fatigue actually considerably reduced by day 7. And there was also early conversion to negative RT-PCR for the COVID-19 virus in the intervention group. So among the secondary endpoints, only these 3 points had some significant difference, but this did not clinically translate to any significant difference in the primary outcome, that is either progression to the severe disease or 28-day all-cause mortality. So what are the strengths and limitations of the study? Strength, I would say, it was actually conducted in the challenging times in the multiple centers across the country under the available circumstances. And there was huge relevance to all the stakeholders, be it the patients or the policymakers or the hospitals or to the community at large. Because if you remember at that time, in the after April or May, when there were initial reports started flowing from US or in China that they're using convalescent plasma. And if you look at the history of the medical science or clinical science, there has been usage of this convalescent plasma for patients with measles, rubella, and many other diseases. So there was when everybody was, trying to catch at straws, trying to find any magic therapy to deal with this disease. When this news or case report started flashing that plasma therapy is curing patients, so there is a lot of hue and cry among the policymakers and administrators of the countries about the healthcare workers about gathering or using the plasma for patients, because patients who are recovering actually they become eligible after 28 days or 6 weeks. And there was a big hope was centered on pinned on this, that those plasma or convalescent plasma can be utilized to treat the new patients who are presenting to the hospital. And I remember many cities in our country, including our own state, there was a lot of political will to open this plasma therapy centers. And the Chief Minister himself actually participated in inaugurating 4 plasma therapy centers in the state. So that was, the hype that was created. But after I think this study was conducted, it actually solved many of the dilemmas or, the doubts that were there in the minds of people and the scientists. And this study also actually brought into limelight the real life practice scenarios, because if you, as Dr. Babu Abram was mentioning, that we always face trouble in implementing the Western guidelines or protocols. It's very difficult to customize to Indian scenarios. because our population, our kind of healthcare personnel, our infrastructure is so different compared to the West. So very difficult to just to go through their studies and trying to copy paste those ideas or the recommendations in our scenarios. I'm glad that this study was conducted in India. India are under our real life practice scenarios with our limited capabilities of labs and infrastructure. And it can be extrapolated because of the generalizability and the heterogeneity of different centers. You see, there are 29 public hospitals and 10 private corporate hospitals have participated in this study. So this is huge participation, I would say, under that circumstances in the midst of the pandemic peak. And the limitations are, of course, there, as you see many other Western studies also who have been parallelly conducted. And many studies actually have been published in the West in the reputed journals, and they have been withdrawn with apologies also. So I think it is expected that these kind of studies which are conducted on those challenging, difficult times will have some limitations. Most important one is the bias that is being cited due to open nature of the study, because there was no blinding. The assessors or the assigners would know that which treatment is being given to which patient. And probably that could be one of the cause that one of the secondary outcomes, and that is including early resolution of the shortness of breath or fatigue. Uh, that could be one of the endpoints which could have been affected due to the bias. And also the antibody titers were not measured in all the plasmas that were used for donation. This was due to the limitations of the laboratory capacity in all these participating centers. But this is again one of the real life scenarios. And because the study was conducted in heterogeneous centers with different kind of setups and infrastructure and the best of standard care, whatever feasible in those centers, this study has relevance for Indian scenarios. So the take-home message is, though use of convalescent plasma helped in faster resolution of symptoms like shortness of breath and fatigue by day 7, it did not translate to reduction of progression to severe disease or mortality at day 28. So as I was mentioning, for policy makers, it had huge implications because once if you remember, ICMR said that plasma should be used, and it started licensing or giving permission to many centers starting from Delhi all across India. It started spreading like fire. And then it was not an easy task under those circumstances to get the donors, first of all, to get the donors, and then to process their plasma selection and processing their plasma, storing it, and then administering to the patients, COVID-19 positive patients under the correct circumstances with all those aseptic measures. So there was huge resource implications and with financial implications as well for all the centers across the country. And also you would have witnessed many ads on the social media on different platforms, which were actually started blackmailing, selling plasma in the black market. So it had gone up to that extent. So solving that riddle or dilemma with this kind of trial actually has helped us. It also has, this trial investigators have recommended that in future we could have patients who because if you remember, all the patients who were enrolled in the study had some level of neutralizing antibody at the point of enrollment. So maybe in future we can enroll patients who will have no neutralizing antibody, and we may also consider using plasma after checking the antibody levels in the plasma unit itself and using only those plasma which have got high level of antibodies. Then probably we'll know that patients who do not have antibodies at all, and if you're giving them plasma units with high high level of antibodies, what is the difference that is being achieved? This trial, I would say, also has a paved path for a future path for critical care related research by liaising with national agencies like ICMR. Because if ICMR could conduct such a study under those pressing conditions and the peak of the pandemic, then probably in future when things are settling after this season 2, we can look at liaising with this big central agencies to conduct further critical researches in the country, because funds in terms of personal support and statistical support, that will be a great help. That was the first paper. I stop sharing now. We'll take questions or we'll discuss or comments.
No, I think carry on, ma'am. There's no question right now.
Okay. Right. Just give me a moment. I'll open that other trial. Is it visible?
Yes, ma'am. Yes.
Okay. So another trial is regarding the use of an oral vasopressor actually. So this trial, is the screen visible?
Yes. Yes. All good.
Okay. Okay. So this is about use of a oral vasopressor, that is a drug called midodrine. This is known as MIDAS trial. This looked at effect of midodrine versus placebo on time to vasopressor discontinuation in patients with persistent hypotension in the intensive care unit. So this study actually has thrown light on the use of oral vasopressor. If you recall the real life time scenarios in intensive care units, many times we have patients who are in a profound shock or a refractory shock. They come off, usually get enough from high doses of vasopressors, come down to maybe single agent, but they get stuck at a low dose of vasopressors, maybe noradrenaline, just 2 to 3 ml per hour, or maybe not less than 5 ml per hour. But getting rid of that low dose of vasopressor becomes a difficult task. Every time you reduce the vasopressor a little bit, BP precipitously falls, and the nurse or your junior doctor would be ending up increasing the level of the noradrenaline. So those are the cases. Actually, patient would be clinically improving, end organ functions may be improving or restored to normalcy. But number wise, if you see, the patient is stuck with a low dose of vasopressors. But unfortunately, most of the ICU, according to the protocol of those ICUs, it does not allow shifting of those patients out of ICU, because as a policy, probably it mandates to keep patients who are on vasopressors in ICU only. Then it adds to the cost of this patient's treatment as well. So this is one drug which has addressed that issue. This study was actually conducted over a large period of time. I would say this was due to most likely slow recruitment, though it is two subcontinents were there. Like there were three hospitals, two in US and one in Australia. They included mostly the adult patients who are more than 18 years of age and needed vasopressors. The following vasopressors with their particular specifications of the doses, this all indicate actually low doses of vasopressors, be it noradrenaline or phenylephrine or metronidazole. And they were unable to be liberated from ventilator for more than 24 hours. Sorry, it was actually vasopressors, not ventilator. Reversible causes of hypotension were definitely treated, and usual resuscitation protocol was followed. The exclusion criteria were hypotension with evidence of compromise of end organ perfusion. So if the patient was requiring vasopressors and there was evidence of end organ dysfunctions like renal, or it is the capital, or the brain is not perfused properly, patient is unaltered sensorium, or there is liver dysfunction or profound shock, the patient was not included in this. Patient with liver failure, patient with advanced COPDs, or those who had severe LV dysfunctions with ejection fraction less than 30% were also excluded. Hypotension due to endocrine issues like adrenal insufficiency were also excluded. Pheochromocytomas or acute urinary retention thyrotoxicosis patients were also excluded. So this was on a one-to-one randomization protocol was followed. Patients who were in the intervention group or in the test group were given oral metodrine 20 milligram dose TDS versus a placebo. Drugs were continued till ICU discharge or until any of the following occurred, that was either worsening of the hypertension requiring high-dose vasopressors when this drug was stopped, and the patients were mostly excluded from the trial. Signs or symptoms of end organ failure or hypoperfusion or adverse events like serious allergy or death happened. If blood pressure goal was not met for 24 hours without IV vasopressors, then the study drug would be discontinued as per the clinical team. So the endpoints, the primary endpoint was time in hours from study drug initiation to discontinuation of intravenous vasopressors. And discontinuous is defined as vasopressor-free period for 24 hours. The secondary endpoints were time to ICU discharge readiness, ICU and hospital length of stay, and readmission to ICU. So among 530 patients who were assessed for eligibility, only 213 were found eligible. So now if you see over a period of 7 years, they could include or recruit only 213 patients. And of this, only 117 were approached for consent. And finally, only 113 patients were enrolled. of whom only 136 patients were randomized. This is the demographic data with their Apache and the SOFA scores. If you see the indication for ICU admissions, there were almost equal numbers for surgical sepsis-related cases and medical ill reasons. Epidural analgesia was also involved in equal numbers in both the groups, of 18 cases in the test group and in the control group. Duration of vasopressure hours and the before the study drug administration. So we'll come to the endpoints. In the primary outcome was time to vasopressor discontinuation. You see in the midodrine group, it was only 23.5 hours and placebo was almost equal, 22.5 hours. So highly insignificant difference between the two groups in terms of time to vasopressor discontinuation. The secondary outcomes like time to ICU discharge readiness, ICU length of stay, hospital length of stay, ICU readmission rate, everything, there was not much significant difference. However, the subgroup analysis did show the patient who had epidural analgesia at the time of hypotension, they had slight difference in time to vasopressor discontinuation. Only the patients who had epidural analgesia. So this is the curve which shows there was not much difference between both the groups, placebo and the patient group, and the group which received midodrine drug. And the features of this or limitations of this trial is that they had a broad eligibility criteria and included a heterogeneous cohort. That meaning all kinds of surgical patients, patients with sepsis and medical disease patients were included. So that is what has given rise to the heterogeneity of this cohort of the patients that were studied. And patients who were already on midodrine were actually excluded. So that could have added to the selection bias. Sample size was very low, and only 113 patients over a period of recruited over a period of 7 years. That is actually very slow recruitment, and lack of pre-specified subgroup analysis. They did not set their goals for subgroup analysis. I would say normally imagine for patients who are in the surgical group, who had surgical group or who are in the medical group or in sepsis, they should be analyzed separately because different disease processes have different etiologies for hypotension and the causes also for refractory shock. So that could be analyzed accordingly. And this study is actually conducted in 3 centers in US and Australia. So again, extrapolating their conditions to all the countries across the world is a difficult task. So the concluding, midodrine did not reduce time to discontinuation of IV vasopressors in critically ill patients with persistent hypotension. And there is lack of effectiveness with higher rate of bradycardia. It also does not support routine use, off-label use to achieve liberation from vasopressors in ICU, because midodrine has been given a license to be used long since around 20 years ago, and there has been off-label use of this drug going on mostly in US and some of the European countries. I do not think we use it in India, but this study actually does point out that it has no role in terms of reducing the time to discontinuation of vasopressors in ICU patients. And also it has high incidences of bradycardia. So its use is actually not safe. Thank you. I stop sharing now. You can take questions if any.
Any questions? Okay, ma'am, the one thing was the patients, I think a lot of them were post-surgical, if I saw that correctly. And, you know, they were not in sepsis. So the cause of hypotension, they have not delineated.
Say that again, I couldn't hear you actually.
The cause of hypotension, they have not delineated.
So they have actually included all patients, but they have not analyzed the subgroups. like surgical
Yes.
patients or medical patients or sepsis. Sepsis per se, they'll have hypotension, but what
Yeah.
kind of medical patient they had or what kind
Yeah.
of surgery was conducted, those
Yeah.
were not delineated. So that is the thing which is doesn't throw much light on
Actually,
the etiology of hypotension, and it's not responding to the oral drug.
probably these patients had some kind of post-operative SIRS and maybe some degree of sedation and all those things going on, because 60% I think are post-surgical, and a lot of them are on epidural and all those things. And the other thing is midodrine is also, there's some use in liver disease, because liver disease patients have chronically low blood pressure, so people are using midodrine to some extent. And in disease of the spinal cord, where there is a vasodilatation because of autonomic interruption. So there is some use of midodrine going around in patients who are not in the hospital but who need their blood pressure to be increased. And one thing, like you showed, is that it can cause bradycardia because it's an alpha vasopressor. It actually acts on the alpha 1 receptors in the blood vessels and causes vasoconstriction, just like phenylephrine. Phenylephrine is the IV analog, and midodrine is the oral analog in terms of its action. And apart from that, midodrine also causes piloerection and pruritus. Just for our friends, someone is on midodrine, start getting piloerection and pruritus, think of midodrine. So, and the other thing I would like to say is that this is not a very good trial. It highlights the use of midodrine. That's the only thing that we have tried oral vasopressors, because surgical patient would not really absorb also. How are they going to absorb in the first 24 to 48 hours? Midodrine absorption itself is a question mark here.
Yeah, all the indications that you said they are using is off-label uses. That
Yes.
has been actually, brought into light. And India, we do not think, I've not seen usage of midodrine for this liver patients. Might be in the north, I'm not sure. But similar kind of drug like that is orsipranolin. This is Orsidrest. It's an oral drug for boosting heart rate for patients who have got cervical cord injury and bradycardia hypotension. Orsipranolin is being used by cardiologists a lot. It's similar kind of drug, but obviously doesn't have much efficacy. Yes, Dr. Babu, please.
Okay, midodrine is available, and in fact, as was like what Dr. Tapesh is saying, we use it in the ICU when patients are liver patients and renal failure patients needing 1 or 0.5 ml of NORAD, not able to get out. Started with them, and we are able to move them. But I think, as you said, it's off-label, and it's if any of the there are any trainees who are listening to this and are interested, I think it will be a good study to take up and do and see how it works. And because if getting out of the ICU, even if it's 24 hours earlier, will cut down the cost tremendously. So I think it's a worth trying out in a RCT format to see whether it will work or not.
For this kind of purpose of like to get rid of those low dose of vasopressors,
Correct.
many do use the steroids. I have seen many physicians using steroids. It's difficult to support that, agree with that, but
Correct.
even, and maybe midodrine is another off-label drug that can
Correct.
help.
It can.
Right.
I mean, it does, but we don't use it as a first-line drug for hypertensive patients in the ICU. But it is this odd patient who just lingers on with the 1 ml of NORAD, not able to come off. It works.
Right.
What happens in long term, we don't know.
Yeah, and the study, and only good thing that they have done, I like about this design, is that they have chosen patients who have hypotension but no organ dysfunction. End organ perfusion is not compromised. So if any hypotension is accompanied with end organ dysfunction or a compromised end organ function, then something that has to be taken seriously and it has to be treated more aggressively. But somebody who is perfusing all right, pouring good amount of urine, conscious eating, talking, but stuck to 2-3 ml of NORAD or any of these vasopressors, then that is a case that we need to,
Correct.
ask ourselves, review. And for the sake of number, as the first, we're going back to the first trial, that number is not something that we should not be chasing. It is the end organ status. Maybe midodrine is not required if end organ perfusion is all right. Just shut it off and you reset your goals.
Correct.
Yeah.
But I do not know how the protocol in each hospital is. in some, at least my hospital, the ward nurses will not accept a patient if the systolic pressure is less than 90. So it becomes problematic because nurses, they say, no, I'm not going to accept your patient. Then you want something to, the patient is otherwise okay, sitting up, eating meals, but he's on this 1 ml of noradrenaline. So it becomes problematic. So
we also face this actually many times, and I have devised actually, I use make a box in the front of the nursing chat and mention accept blood pressure more than equal to 80, that kind of thing, and it has to be continued for the next shifts.
Are you using phenylephrine in the ICU at any point in time? Phenylephrine infusion?
Yes, we are using, but it's a more on the expensive side, so we don't use it as an infusion, but as rescue therapy we are using.
Yes, especially when there is no central line, and NORAD has to go through central line. That is the dictum and our protocol is. So when there is no central line, I many times recommend that use that, because it comes in a vial, and you can immediately use it through peripheral line to buy time to get do central lines. I think that's a good alternative, but not long term.
But it is not actually. The first 3 vasopressors are in the sepsis guidelines. It's not there, as you know.
No.
NORAD and Epi.
Correct.
Just a temporary thing to do, to buy time before you can start using other vasopressors, get the lines to use other vasopressors. Because NORAD or vasopressin you cannot give through peripheral line.
Okay, having said that, there's one of my PGs who's doing a study on noradrenaline to a certain dose. Okay, not through the peripheral line, through a peripheral line.
Yeah,
so
because even the data for phenylephrine is actually lacking. That's what I had read. That's why there is no recommendation. Whatever data we have, it does not score above the first 3 vasopressors, phenylephrine, because it would and it does cause bradycardia also.
Correct, it does.
Beta blockers coming in, use of beta blockers for sepsis to reduce tachycardia. You use phenylephrine, you will automatically reduce the tachycardia. So might just help if you do that. Also would be a wonderful study if somebody wants.
So I have one comment on the first Placid trial. It's not on the trial, but it is on, as you said, it is on how it was done. I think as intensive care community, we realized that we can do large scale studies in India, which always we never did. One. Second, the COVID period has also showed the world that India can be part of large randomized control trial. See, before this, we were part of only one randomized control trial. I think it was, if I'm not mistaken, the HFO trial, one of the HFO trial, I think 1 or 2. Otherwise, we never were part of any of the big randomized control trial in multicentric trial in the world. But now, Remap Cap, a lot of these caps, solidarity trial, we are part of the trial. So I think that is one good thing which has come out of COVID. Now, Indian ICUs are getting into the large randomized control trial, and we have shown that we can also do it. I think that this should be the beginning, and maybe there should be a way that we Indian ICUs should be collecting data and then maybe bringing out our own studies.
Yeah, and as a society also, ICCM can actually look at licensing with ICMR, because if this kind of project we propose to them, I do not see any prohibitions from their side not coming forth and helping us in funding and personal and statistical support. That will be a big help, because intensive care in India is actually 85% is private and 15% is public, right? So, but it is, you would also agree, being in a bigger setup also, it's so challenging to conduct researches because lack of support and infrastructure. We are good at delivering healthcare, but research, we always take a back seat. So in those, that front, actually, ICMR like of kind of organizations can do a big help.
Yeah, I mean, we have got a research committee. I think
we will put forth. We'll put forth. Actually, I'm also thinking of in the next EC. Right, we'll be meeting there.
Okay, then I think Dr. Sharmili ma'am, thank you. Thank you so much for, and that was kind of educative also, the way you analyze the studies, because these guys have to know how to analyze and talk about the studies also. That was good for the trainees. So sir, you're always you know the pulse of the trainees, and there are some other junior intensivists and some other who are start joining in. So thank you very much. And Dr. Binilla has left, and because she had a patient on ECMO, she told me earlier only she would leave. Dr. Bansari, he had 3-4 patients crashing, COVID in Bombay. I don't know how he actually agreed to come, but he had to go. And Srinivas sir, again, COVID taking over, and he had to be in the ICU. So we had, managed to go through this with COVID going across the country. And I thank everybody. And I would now like to inform everybody that the next session is on organophosphate poisoning. Organophosphate poisoning, which is again an area where we need a trial from a country, a proper trial. We do not know what is the dose of atropine. Above all, we do not know PAM. Nobody knows anything about PAM, whether to give or not to give.
No, Dr. Tapas, no, don't. We have got a meta-analysis from Vellore on PAM. I think you should get one of Belina back on that panel.
Sir, we don't agree with that. There are many meta-analysis. Meta-analysis is not.
Correct. No, I think you should. They have an opinion. I'm not saying that it's right or wrong. Yes. But the Vellore guys have an opinion on PAM. I think you should get them onto the panel.
Absolutely, Dr. Peters, we have due respect, but so much conflicting data, sir, both ways. It's both ways. So,
correct, exactly. So JVP has got a very strong opinion on it. I think it will be nice to have him on the panel next week.
I will talk to him. He said he was busy. I'll talk to him again. I talked to him. He said he was busy or something.
No, but, yeah. If you can
maybe
get him
Dr.
on the
Babu
panel.
can talk to him and convince him to be here. And I've said also organophosphorus in a COVID positive patient. We'll see how to deal with that.
So organophosphate, one place where we need a proper trial. Anyway, guys, so next week organophosphate, and it'll be taken by Dr. Soren Panja from Calcutta. Okay, guys, see you. Bye.
Yeah, I would like to thank Dr. Tapas, especially for his excellent job, and your efforts are really highly appreciated.
Thank you, ma'am.
And I think trainings that I get from, at least from my center, it's just been highly useful.
It's thank you, ma'am, with everybody, Dr. Babu.
Thanks, Dr. Babu, and all the trainees.
Yeah, everybody.
Thank you.
Enjoy the rest of the evening. Thank you.
Everybody. Bye. Thank you. Thank you, everybody. Thank you, guys. Students, I hope you learned. Bye.